Hello all, welcome back. We're continuing with the MRCP Part 1 sample questions explanation series. Here is Part 8. Question 141. A 76-year-old man presented with 3-year history of gradually enlarging a red patch on his leg. He was an ex-serviceman who had worked in the Mediterranean for several years. On examination, there was an erythematous scaly patch, 5 by 6 in diameter on his shin. The edge was well demarcated. What is the most likely diagnosis? So he's 76, okay, and there is 3-year history of gradually enlarging red patch on the leg, and he has worked in Mediterranean for several years. So there is some indication saying that he had severe sun exposure, prolonged sun exposure, and there is some patch which is enlarging. What is the most likely diagnosis? The options are Bowen's disease, discoid eczema, pityriasis rosea, psoriasis vulgaris, secondary syphilis. So we look at each options. Bowen's disease, it's a kind of like a pre-malignant lesion of the skin, can be due to prolonged skin exposure. Discoid eczema, the rash is not eczematous, right? It is erythematous and scaly patch. And there is also no history of eczema or anything. This is over 3 years and he's already 76. So unlikely. Pityriasis rosea can be this erythematous lesion. But in pityriasis rosea, there will be some mention of a herald patch. That is one patch that is coming first, and then that spreads. Here, over 3 years, there is only single patch which has increased in size. It has not spread. Okay. And psoriasis vulgaris. Psoriasis again can be scaly. It can be in sun exposed regions, an extensor surface in hands and all. But here just one lesion, not spread to any other area. Secondary syphilis, no mention of any mention of an STD or some symptoms regarding that. So here the answer is Bowen's disease. Okay, here you see an erythematous lesion, which is like spreading out. Okay, it's spreading out. The borders are not regular. This is actually a type of pre-malignant lesion which can progress to cancerous lesion. It's a type of skin cancer that's on the surface, and it can be called squamous cell carcinoma in situ. It has not developed into a squamous cell carcinoma yet because there is no breach of the basement membrane. It is called squamous cell carcinoma in situ. So that is Bowen's disease. Again, sun exposure is one of the commonest implications. Next question, a 45-year-old African Caribbean man was referred to the outpatient clinic with uncontrolled hypertension. On examination, BP was 174, over 90 for examination was otherwise normal, creatinine is 105, was the most appropriate treatment. So as per NICE guidelines, less than 55 years, you give ACE inhibitors, more than 55 years, you give calcium channel blocker. Okay, but here the race, the ethnicity of the patient, it's African Caribbean. In those patients, the recommendation is to start calcium channel blocker initially. So this is the trick in this question. Though the patient is less than 55, we start with calcium channel blocker. So amlodipine is the answer. Next question. A 51-year-old man presented with 2-month history of intermittent breathlessness and a 1-year history of a blocked nose. He's been found to have angina 2 years previously and was taking aspirin, ramipril, simvastatin, atenolol, and omeprazole. FEV1 is 2.5 liter, 75% of predicted. FVC is 4 liter, 88% of predicted. So there is reduction in FEV1, and there is more reduction in FEV1 than FVC. Here the patient is presented with breathlessness, 1-year history of blocked nose. What is the drug that is more likely to cause? Options are aspirin, atenolol, omeprazole, ramipril, simvastatin. We look at each of the options. Aspirin. Aspirin can be associated with your nasal blockade, bronchiectasis, aspirin sensitivity. You know what that is called? It's called Samter's diet. That is Okay, and then, in that there is asthma-like picture. There is canine sinusitis, nasal polyps. So this blocked nose can be due to polyp. Uh, and aspirin sensitivity, that's called a Samter's triad. So aspirin can be implication. Other one we look at in alone is a beta blocker that can exacerbate asthma-like symptoms, but here there is no previous history and all. Omeprazole, not likely. ACE inhibitor, it can cause chronic cough. Okay, ACE inhibitor can cause chronic cough and angioedema. Simvastatin, no. So it is aspirin. Next question. A 60-year-old woman with advanced metastatic cancer was treated with subcutaneous haloperidol infusion. What is the main site of action of this antiemetic? Direct and fact-based question. Haloperidol, it's acting at the area postrema. So as you can see, this is various antiemetic drugs and their site and mechanism of action. So here, this chemoreceptor trigger zone, CTZ, is called the area postrema. Okay, and then they have a vomiting center. This is all in the medulla oblongata. There's so many receptors involved, which is the D2, 5-HT3 or 5-HT3 receptor. There is NK1, there is opioid mu. And the drugs, the main classes are anticholinergics like hyoscine and scopolamine. Here they are given the numbers to each thing. So from the ear, the inner ear, through the H1 and muscarinic receptors, the information passes into the vomiting center that can induce vomiting, especially in seasickness or positional thing. Okay, may be associated with vertigo. From the GIT also, information passes by the 5-HT3 receptors into the vomiting center. And from the cortex, okay, from the brain also, the signals pass. So here, anticholinergics are acting here through the muscarinic receptor in the inner ear. Hyoscine or scopolamine and dicyclomine are the drugs from the anticholinergic class. Next class is H1 antihistamines, and again in the inner ear. So for motion sickness, you can give either hyoscine or any of the antihistamine like promethazine, cinnarizine, meclizine, doxylamine, diphenhydramine, and dimenhydrinate. So they both are in the inner ear, anticholinergics and antihistaminics. Then you have 5-HT3 antagonist, again on the chemoreceptor trigger zone or area postrema, which are your ondansetron and other cetrons, dolasetron, palanosetron, etc. Then D2 antagonist like metoclopramide, domperidone, haloperidol. This was in the question, haloperidol, again acting on the chemoreceptor trigger zone by the D2 receptor. This can have, since it is acting on the D2, it can have Parkinsonian side effects, okay, extrapyramidal side effects, or it is contraindicated in Parkinsonian patients. Then NK1 antagonists are aprepitant, posaprepitant, again in the chemoreceptor trigger zone. Then we have prokinetic drugs, mainly concentrated in the GIT. Okay, 5-HT3 is also in the stomach also. You can see ondansetron and all. So prokinetic drugs are cisapride, rucalopride, metoclopramide, domperidone, etc. And the one drug which can again increase mortality and also an antibiotic is your erythromycin. So these are some of the antiemetic drugs and their site and mechanism of action. Next question. A 52-year-old woman present with 6-month history of upper limb weakness that had progressed to affect her lower limb. Over the previous 2 months, she had been complaining of increasing dysphagia to liquids more than solids and worsening shortness of breath at rest. On examination, she had a brisk jerk, tongue fasciculations, and MRCP grade 4 muscle power and shoulder abduction and hip flexion bilaterally. What is the most likely diagnosis? So we'll dissect the question and see what all problem the patient is having. So she initially had upper limb weakness, now progressed to lower limb weakness. She had been complaining of increased dysphagia to liquids more than solids, can be a bulbar problem, worsening shortness of breath at rest, brisk jaw jerk. Brisk reflex is a UMN finding. Again, weakness and all can be UMN finding. Fasciculations but is a element finding. So there is both UMN and element finding. And MRC grade 4 muscle power in shoulder abduction and hip flexion bilaterally. What is the diagnosis? Options are motor neuron disease, multiple sclerosis, myasthenia gravis, spinobulbar muscular atrophy, syringobulbia. So UMN and element findings coexist in motor neuron disease. Okay, motor neuron disease. One of the varieties is amyotrophic lateral sclerosis. Okay, how about your multiple sclerosis? How do they present? Multiple sclerosis, usually the commonest variety is relapsing remitting. That is when the patient is having neurological disturbance, then that goes into remission completely. They can have either motor, sensory or whatever. They goes in for complete remission, and then after maybe 6 months, 1 year, they come with another set of symptoms, completely different from the previous, but again neurological. So that can be presentation in multiple sclerosis. Commonest variety is relapsing remitting, not the case here. This is kind of a progressive weakness with 6-month history, both element and UMN findings. So that could be multiple motor neuron disease. What about myasthenia? Myasthenia gravis, again, there can be ocular muscle weakness mainly, presenting with ptosis. There can be decremental response on nerve conduction study. Again, not the case here. Spinobulbar muscular atrophy, where there is bulbar defect, and the spinobulbar muscular atrophy, again, it's a type of motor neuron disease itself, but the commonest variety is, like I told, ALS or amyotrophic lateral sclerosis, which is also called Lake-Reddick syndrome. But in Kennedy disease, which is the spinobulbar muscular atrophy, amyotrophic lateral sclerosis is also called Lou Gehrig disease. Here, spinobulbar muscular atrophy is also called Kennedy's disease, which is having even a slower progression, more likely with both element and UMN findings, with fasciculations and all, they do present, but here it is 6-month history. Spinobulbar usually have even a slower progression. Syringobulbia, that may not adequately explain the upper limb weakness, which is followed by the lower limb weakness. Because there is bulbar dysfunction, but if something is compressing from inside of the spinal cord, the first of the motor fibers to get affected will be upper limb itself, but along with that there can be the pain and temperature defect, and also not a picture like element and UMN findings. So here it is motor neuron disease. Next question. The Health Survey for England recorded age, sex, ethnicity, height, weight, smoking status, alcohol consumption, and systolic BP in a representative sample of the population. What is the best graphical method for illustrating relation between age and BP? So age is also a continuous variable, and BP is also continuous numbers. For that you give scatter plot. Pie chart you usually use for proportions and all. Okay. Histogram also, one may not be a continuous variable. Forest plot is for meta-analysis. Block diagram, not the case, so it is scatter plot. Next question. A 17-year-old girl was informed at a blood donation session that she was not able to donate blood. She was a carrier of sickle hemoglobin. She had had a pelvic fracture following a road traffic collision the previous year, for which she had required a blood transfusion. She had been on holiday in Kenya 3 years previously. She did not smoke, drink, or use recreational drugs. On examination, she had a tattoo on her arm. She weighed 63 kg. What is the most likely reason for her not being able to donate blood? So this is in accordance with the NICE guidelines for blood transfusions. Options are history of travel to malarial area, but that was 3 years previously, so that is not the answer. Previous blood transfusion, that is one of the contraindication for donating blood. Sickle hemoglobin carrier is not a case. Tattoo, there is no mention when she had gotten a tattoo. And her weight is adequate. So she's weighing 63 kg. So the reason is previous blood transfusion. Next question. 47-year-old man presented with episodes of feeling that he was about to have a heart attack. Associated palpitations and sweating. He recovered fully within 30 minutes. He had experienced 12 episodes over the previous 4 weeks. He had been working long hours and was concerned about a forthcoming interview for a new job. Examination was normal. What is the most likely diagnosis? So he is having heart attack like feeling. That means he is having palpitation, he is having sweating, and he is recovering fully within 30 minutes. And he's had multiple episodes in the previous 4 weeks. So this multiple episodes and stressful history, that indicates more of a psychiatric disturbance like a panic attack and all, other than a cardiovascular disorder. So it is panic disorder, panic attacks. Other options are acute stress reaction. That does not explain the repetitive symptoms, right? Adjustment disorder is not when the patient is not able to accept something, some of the event that has occurred in his life or in his close one's life. That is not the case here. Generalized anxiety disorder, illness anxiety disorder. Illness anxiety disorder when the patient is concerned that he may have a disease, despite many of them telling that you don't have the disease. So here it is panic disorder, panic attack. Next question, 68-year-old man became acutely breathless following admission with a 2-week history of nausea, vomiting and diarrhea. Despite fluid resuscitation, he had remained anuric 6 hours after admission. So he's come with acute breathlessness. So there is some kind of a fluid overload because the patient is having is being anuric. Okay, so and the patient had 2-week history of nausea, vomiting, and diarrhea, and he was fluid resuscitated, and he is anuric. So that means fluid has been resuscitated. So now he's in a fluid overload state. His BP was 104/63, JVP was 10 cm above sternal angle. So there is absolute increase in the fluid status of the patient. Respiratory rate was 32 breaths per minute. In ERDS like picture, right? Or maybe pulmonary edema. Here by basal respiratory crackles. So pulmonary edema and pitting edema in both angles. So angle edema also. Sodium 138 normal, potassium is 5.6, maybe due to the renal shutdown. Bicarb 12, the patient is in acidosis. Urea is 29, urea is high. Creat is 640. So absolute indications for dialysis is your hyperkalemia, refractory hyperkalemia, acidosis, uremic pericarditis, uremic encephalopathy. Okay, fluid overload, maybe some toxins. So here are some of the indications of absolute fluid overload. He's been anuric. There is hyperkalemia, acidosis. So what is the next step in management? You go for hemodialysis. You can't give furosemide because there is no point. The patient is in renal shutdown with acidosis and hyperkalemia. The patient may worsen anytime soon. So you have to arrange an emergency dialysis for the patient, hemodialysis. So what are the absolute indications for dialysis? It is acidosis or acute intoxication with some dialysable drugs like maybe lithium. Okay, then encephalopathy, uremic encephalopathy or electrolyte disturbance like your hyperkalemia. I stands for intoxication with some drugs. O means fluid overload. U means uremic pericarditis, uremic encephalopathy. So this is AEIOU, which are the absolute indications for dialysis. Here the patient was having acidosis, he was having electrolyte disturbance, which is hyperkalemia. The patient is in a state of fluid overload, and there is uremia. Okay, so that is indication for dialysis. Next question. An 87-year-old woman was admitted with increasing drowsiness which resulted in her not eating or drinking. She had a history of dementia and was living in a nursing home. Investigation showed 178 sodium. Okay, so she's not eating or drinking. So high sodium may be due to dehydration. Potassium is also high. Urea is high. Could be due to dehydration. Create 190. Pre-renal kidney injury maybe. Fasting plasma glucose is 4.5 normal. What measurement correspond closely to her serum osmolality? So it's a mathematical question. What is her serum osmolality? So the formula for calculating osmolality is 2 into sodium plus potassium. Okay, plus glucose plus urea, all in millimole per liter. Okay, so here all in millimole per liter, sodium, potassium, urea and glucose. We don't need creatinine for calculating osmolality. So we'll do a quick math. 2 into 178 plus 6. 178 plus 6 is 184. 184 into 2 is 368. So that comes 368. 2 into sodium plus potassium is 368. What about glucose plus urea? Glucose is 4.5, roughly around 5, and urea is 18. 18 plus 5 is 23. So plus 23 or 22.5. So what that comes about? It comes about 391. We look at the options. 210, 310, 350, 390, 410. What is the closest value? It is 390 milliosmol per kg. That is the unit for calculating serum osmolality. Next question. A 32-year-old man presented with increasing headache and facial weakness. 2 weeks previously he had developed a right-sided facial palsy with pain behind the right ear. The previous summer, he had camped with his family in the southern Germany. Examination revealed mild photophobia, neck stiffness, and a right lower motor neuron facial weakness, but no other neurological sign. Which organism is most likely caused? Options are Borrelia burgdorferi, which is causative organism for Lyme disease, Brucella abortus, which is causative for brucellosis, Cryptococcus neoformans, mostly causing diarrhea in HIV patients, Listeria HIV or immunosuppressed patients, Listeria monocytogenes, mostly causing meningitis in elderly and immunosuppressed, Neisseria meningitis, again causing commonest organism for one of the commonest organisms for causes of meningitis. Here there is travel history and there is element facial palsy, so there is nerve weakness. So this is suggestive of Lyme disease, which is a tick-borne disease, and that can cause nerve palsy, cranial nerve palsy. So the history goes with the diagnosis, that is caused by Borrelia burgdorferi. Borrelia burgdorferi. Next question. 76-year-old woman presented with 6-month history of urinary urgency, nocturia and urge incontinence. She was taking immediate release oxybutynin, but this was discontinued after 6 weeks because of lack of significant improvement in severe mouth dryness. Rectal and vaginal examinations were normal. Midstream urine culture showed no bacterial growth, and post-void residual urine volume is 40 ml. Not very high. What is the most appropriate next treatment? So the patient had UTI, urinary urgency, nocturia, and urgent incontinence, and she was taking oxybutynin. Okay. Sorry, there is a 6-month history of urinary urgency, nocturia, and urgent incontinence, which means the patient had some kind of continence issue. And this is having urge incontinence. She was given oxybutynin, which is antispasmodic or anticholinergic, and she had but severe mouth dryness, one of the commonest side effects of anticholinergic drugs. We have been asked what is the next line of treatment for urge incontinence. Options are desmopressin, duloxetine, flavoxate, propanthalin, solifenacin. The answer is solifenacin. Okay, solifenacin is again an anticholinergic, but it has a better side effect profile than oxybutynin. So when the patient has developed some serious side effect of oxybutynin and they had to discontinue oxybutynin, you have to go for solifenacin. Next question. A 68-year-old woman presented with a 3-day history of discomfort when brushing her hair, pain on chewing, and an episode of blurred vision. A blood test was performed to check ESR and serum CRP. What is the most important next step? So there is history of discomfort when brushing your hair. This history alone should make you think of GCA, giant cell arteritis. You have to rule out giant cell arteritis, or when there are other symptoms suggestive of giant cell arteritis, one of the commonest concern and biggest concern that you have is blindness, because here the patient already had blurred vision. So you have to give some drug to prevent development of blindness, that is prednisolone. So what is the most important next step? Options: a CT scan, measure ANCA, ANCA, prescribe diclofenac, prescribe prednisolone, temporal artery biopsy. Temporal artery biopsy can be diagnostic, but not always, because there are skip lesions and you can get misdiagnosed. But here the concern is development of blindness, so you have to prevent that somehow by prescribing steroid. So this is a case of giant cell arteritis. Not able to brush the hair is one of the history they try to give in GCA. Okay, so this is giant cell arteritis. It can be a clinical diagnosis. You may not always need a temporal artery biopsy. ESR can be high and CRP can be high. That alone should make you think of GCA and prescribe prednisolone. Next question. A 52-year-old woman presented with an episode of weakness on the left side of her face and left arm that resolved after 3 hours. She was otherwise well and had no significant medical history. BP was 110 over 75, ECG showed AF with a rate of 110, echo showed a normal heart. Treatment was started with atenolone and warfarin. She underwent a successful DC cardioversion 4 weeks later. How long should she continue warfarin therapy? So, how long should she continue warfarin or an anticoagulant? She had a history of TIA, right? She had a history of TIA. Okay, so this is about the Chartuva score or the Hasbled score. In the Chartuva score, if there is a previous TIA or a stroke-like event, that has high score, right? And the patient had AF. The patient had there is risk for developing stroke. The patient is 52 years old. 75 is a higher age, but again, the patient is having high age. So how long should she continue? She should continue it for lifelong. Okay, she had AF and one of a stroke or TIA-like event. So she had to continue that lifelong because there is high risk for developing stroke. Lifelong. Next question. A 54-year-old woman presented with 3-hour history of severe anterior chest pain. ECG showed 3 mm ST depression in V1 to V3 with upright T wave and tall R wave. So there is ST depression in V1 to V3. V1 to V3 or anterior leads with upright T and tall R. A diagnosis of acute MI was made and she was referred for primary percutaneous coronary intervention. Which coronary artery is most likely to be involved? See, here they are testing us whether we know what kind of an MI is this. What kind of an MI is this? ST depression MI. Yeah. See, here there is ST depression, but there is no T wave inversion. There is upright T. So this is like a there can be some ST elevation in the mirroring leads of V1 to V3. So that are your posterior leads. So if you connect posterior, then there you can see ST elevation. So this is a case of posterior MI. And which is the vessel? It is right coronary artery. Okay. But here in the option, we are given circumflex, first septal branch of left anterior descending, left main stem, mid left anterior descending, proximal left anterior descending. Here RCA is not given, so it is circumflex, because in patients who the posterior side is not supplied by RCA, they are being supplied by circumflex artery. So it is a case of posterior MI, and circumflex or RCA is one of the implicating vessel. Circumflex because it is a posterior MI. Next question. What is the site of originating Origin of circulating B-type natriuretic peptide in a patient with chronic heart failure. Direct fact-based question. Where are BNP produced? It is from the cardiac ventricles. Cardiac ventricle. Your juxtaglomerular apparatus produce renin, not your posterior pituitary gland. Posterior pituitary gland release your produced oxytocin and vasopressin. Hypothalamus produce all the releasing type of hormone. That is the cardiac ventricles. Next question. A 25-year-old man presented with 5-day history of foul smelling, diarrhea, abdominal pain, nausea, bloating, and flatulence. He had returned from a holiday in Borneo 1 week previously. On examination, he appeared dehydrated. Examination was otherwise normal. Stool microscopy showed motile trophozoites and cysts. What is the most likely causative organism? So there is trophozoites and cysts. So the option is Giardia. What about the others? E. coli, non-57, can cause HUS, hemolytic uremic syndrome. They can again cause diarrhea followed by HUS. Shigella cause dysentery. Cryptosporidium parvum can cause diarrhea in immunosuppressed patients. Campylobacter jejuni is implicated with development of GBS post-diarrhea. So here the case is diarrhea because there is trophozoites and cyst. There is a parasite. Next question. A 45-year-old man presented with 2-year history of fatigue, 4 kg weight loss, and pruritus. He also complained of long-standing diarrhea with occasional passage of blood. He had drunk 20 units of alcohol per week for many years. On examination, he was mildly jaundiced. Serum albumin was 38. Total bilirubin is 95 high. ALT is 50. ALP is also high. What is the most likely diagnosis? So there is 2-year history of fatigue, 4 kg weight loss, and pruritus. And there is long-standing diarrhea with occasional passage of blood. So long-standing diarrhea with occasional passage of blood can be your ulcerative colitis. Okay, ulcerative colitis. That along with your pruritus and weight loss and all, which are just primary sclerosing cholangitis, which is a kind of cholestasis-like event. Because here bilirubin is high, the ALP is high, which is cholestasis. There is history of diarrhea and passage of blood, so that indicates ulcerative colitis. So this is primary sclerosing cholangitis. Next question. A 47-year-old man with a history of long QT syndrome presented with 2-day history of productive cough and rigors. He was found to have left lower lobe pneumonia. Which antibiotic is most likely to further prolong his QT interval? So what are the QT prolonging drugs? That is a question. Options are amoxicillin, ceftriaxone, clarithromycin, coamoxiclav, doxycycline. So among the antibiotics, one of the drug that is likely to increase the QT interval is clarithromycin or your azithromycin. Okay, and other drugs which can increase the QT are antiarrhythmetics, mainly amiodarone sotalol, then antidepressants, okay, and your antiepileptics like levetiracetam, okay. So these drugs can cause can prolong QT, and electrolyte disturbance maybe can cause also QT prolongation. Next question. A 21-year-old woman presented with 12-month history of amenorrhea following discontinuation of combined oral contraceptive pill, which she had been taking for 2 years. She had undergone normal menarche and had a regular menstrual cycle until she started training to run marathons. On examination, of BMI is 18. She had facial acne and normal secondary sexual characters. What is most likely cause of her menstrual disturbance? So she had a menarche and regular cycles, but it was starting to get irregular when she is trying to run marathons, and her BMI is low also, and she has normal secondary sexual characters, but now she is having amenorrhea. So is it hypothalamic amenorrhea, macroprolactinoma, polycystic ovarian syndrome, post-contraceptive pill amenorrhea, premature ovarian failure? So this is due to low BMI and all. That is called hypothalamic amenorrhea. The hypothalamic hormones will be low here. In macroprolactinoma, prolactin levels will be high, and we can expect some of the other manifestations polycystic ovarian syndrome, the BMI would be high, the patient would be obese. Okay, there can be irregular cycles, there can be hirsutism. Post-contraceptive amenorrhea, not the case. Premature ovarian failure, no. So it is hypothalamic amenorrhea. Next question. An 82-year-old man developed agitation, confusion with visual hallucination one day after surgery for a hip fracture. His family reported that he had been forgetful for the past year but was otherwise independent. On examination, was easily distracted and could not comply with the mental test examination. What is the most likely diagnosis? So it is post-surgery in an elderly patient, and they developed agitation, confusion, visual hallucination. So that suggests delirium. Okay, delirium. Other options are unlikely, so it is delirium. Next question. A 32-year-old man presented with weight loss and feeling generally unwell. On direct questioning, he had been having dizzy spells, especially on sudden changes in posture. On examination, he was stand. There was a postural drop in BP. What is the most likely biochemical finding? So there is weight loss, general unwell, and disease spells, especially sudden change in posture. He was stand. Okay, and postural drop in BP. So drop in BP, disease spells may indicate adrenal insufficiency. So what is the biochemical finding? Options are free cortisol 60, which is normal. Fasting plasma glucose 3.2. Plasma glucose in this patient would be low because of adrenal insufficiency. Plasma adrenocortic tropic hormone high, 95. That can be there because there is also tanning and adrenal insufficiency. So due to the lack of negative feedback, ACTH will be high. Serum potassium 4.6. Potassium will also be low. Sodium 148. Not the case. So actually adrenal insufficiency, there is hypoglycemia, hypokalemia, hypotension. Okay, and ACTH will be high. Next question. A 57-year-old woman was found to have cervical cancer and was treated with surgery followed by chemotherapy with cisplatin. What is the most likely adverse effect of this treatment or cisplatin therapy? Acute hepatitis, cardiomyopathy, hypocalcemia, pulmonary fibrosis, sensory neuropathy. So it is sensory neuropathy. Hepatitis can be in other kind of drugs. Even your anti-TB drugs can cause hepatitis. Cardiomyopathy, among the anti-cancer drugs, cardiomyopathy is a common implication with doxorubicin or trastuzumab. Hypocalcemia, not the case. Pulmonary fibrosis can be with bleomycin. Okay, so here cisplatin causes peripheral neuropathy. Next question. A 72-year-old woman presented with progressive tiredness over the past few months and was found to have iron deficiency and anemia. She had osteoarthritis and was regularly taking ibuprofen and paracetamol. Upper GI endoscopy showed 1 centimeter duodenal ulcer with no evidence of recent bleeding. H. pylori negative. She was treated with omeprazole. What is the most appropriate next investigation? So an elderly 73-year-old woman with iron deficiency anemia. She had osteoarthritis, taking ibuprofen. And upper GI is not highly suggestive and indicating this iron deficiency anemia. There is 1 centimeter ulcer with no evidence of bleeding, but there is bleeding from some other site. That is why she is having iron deficiency anemia. We have to rule out some malignancy, especially in an elderly. Okay, so when upper GI endoscopy is done, you have to do a lower endoscopy or a colonoscopy. Okay, colonoscopy to look for some of the sites of bleeding. Later on, you can do other investigations. Okay, next question. A 53-year-old woman presented with painful right angle was found to have a partial lower tibia fracture. Creatinine is 122. Calcium is low, 2.05. Phosphate is low. Alkaline phosphatase is high. Parathormone is high. Serum 25, dihydroxycholecalciferol is low. So we look at the primary problem. So creatinine is 122, a bit high. Serum 25, hydroxycholecalciferol or the active form of vitamin D is low. So since vitamin D is low, your calcium can get low, phosphate can get low. Since both these are low due to feedback mechanism, VPH can be high. So that explains all. We've been asked what is the treatment of choice. Alendronic acid, that is given in osteoporosis, that is bisphosphonate. The calcium supplementation, polycalciferol, pamidronate disodium phosphate supplementation. So we've identified what is the initial problem. So that is vitamin D deficiency. So you have to give vitamin D, polycalciferol. Next question, a 43-year-old woman presented with 2-month history of progressive muscle weakness and shortness of breath. On examination, there was proximal limb weakness and crackles at both lung bases. ESR is 55, serum creatinine kinase is 3500. So 2-month history of progressive muscle weakness and shortness of breath. Proximal limb weakness, crackles at both lung base. Creatine kinase is very high. What does that suggest? So there is progressive muscle weakness and there is also proximal limb weakness. That suggests polymyositis or your dermatomyositis. Dermatomyositis also has skin manifestations like heliotrope rash and all. Along with raised serum creatinine confirms the diagnosis of polymyositis. Okay, so options are CIDP, chronic inflammatory demyelinating polyneuropathy, inclusion body myositis, myasthenia gravis, polymyalgia rheumatica, polymyositis. So it is polymyositis with raised creatinine and proximal limb weakness. So you can see polymyositis is symmetric proximal muscle weakness, both polymyositis and dermatomyositis. Dermatomyositis also has skin manifestations like heliotrope rash, Cotron's papule, mechanic's hand, shawl rash and all. And the treatment is steroid. Okay, polymyositis has anti-Jovan antibodies, and they can again have proximal muscle weakness here, like respiratory weakness. Okay, and the diagnosis is by muscle biopsy, and they affect the proximal muscle. Next question, a 37-year-old woman with a 1-day history of abdominal pain and diarrhea. She was drowsy and hallucinating and had widespread purpura. Hemoglobin is 92, white cell count is 13,300, platelet is 17,000, creatinine is 195. What abnormality is most likely to be present on blood film examination? So abdominal pain and diarrhea, she is drowsy, hallucinating and widespread purpura. What does that suggest? Okay, 1-day history of diarrhea, abdominal pain. Now the patient is hallucinating, widespread purpura and drowsy. And there is low platelet, a bit high count, anemia, and creatinine is also high. That can suggest hemolytic uremic syndrome, right? Hemolytic uremic syndrome. Post-diarrhea, neurological manifestation and purpura, and there is hemolysis. What is the likely picture on blood film? Options are acanthocytes, elliptocytes, fragmented cells, stomatocytes, and target cells. Since there is hemolysis, there are fragmented cells. That is. Okay, so that's all for today. We'll continue with the series and we'll finish off the sample questions in the RCP website. Hope you all liked it and follow for more updates on MRCP. More videos are coming up. Thank you so much.